good afternoon, and thank you very much for that introduction. So we are here to run what you might have seen on the programme as the NNed India workshop. So what we're going to be talking to you about this afternoon at this very momentous gathering, I must say, the World Congress of Public Health being hosted in India after at least a couple of decades. We're going to be talking to you about one of the very important but perhaps more marginalised areas of public health and healthcare, and that is nutrition and nutritional care. So we'll be talking through what we think is the perfect combination, nutrition education and leadership, which we believe can lead to both improved clinical and public health outcomes. As the anchor just said, we're here from the UK Nutrition Education Innovation Programme. We represent several different UK-based organisations, the British Dietetic Association, the Medical Research Council's Human Nutrition Research Unit, and we also have an international link with the Society for Nutrition Education and Behaviour. However, we're anchored in two parts of the UK through our connections with two universities in particular. So one of those is the University of Cambridge, and therein we're connected with the School of Clinical Medicine, as well as one of the constituent colleges of the university. We also have a base at the University of Ulster in Northern Ireland, and this really gives us a pan-geographic representation from across the UK, but also more widely. So this afternoon, what we're going to do is myself and my colleague Pauline Douglas will talk you through some introductory concepts, after which we will break out into groups, do some small group work, and then we're going to get some of you to feedback, so be ready to share your thoughts, not just within groups, but on this platform. But before that, just winding back to our core mission and what we do. So really at the heart of everything lies our aspiration of laying strong foundations of nutrition knowledge that are relevant to both clinical as well as public health practice. And in doing so, we work as an interdisciplinary group. So we're a virtual strategic partnership that comprises input from doctors, dietitians, nutritionists, and a range of other healthcare professionals. So just at this point, before I go further and introduce individuals who are here, can I have a show of hands as to how many people in this audience have some connection with nutrition? So probably about 80%. How many of you are from the medical profession? And are any of you students? Okay, so a good deal of tomorrow's doctors, so drivers of the future. Are there people here from generic public health? More general public health, preventative medicine? Any people who are from other healthcare professions? Okay, so we've got a bit of a mixed group, and it's a real pleasure to have that interdisciplinary mix. So some of our key people today are myself. I chair the NNed group. I'm a medical doctor as well as a registered public health nutritionist. And some of the things that I have the pleasure of doing are actually running the nutrition and diet survey for the UK nations. And we also run a research group in Cambridge which looks at nutrition and cardiovascular prevention. My co-principal investigator within the NNed group, Pauline Douglas, is a dietitian, emeritus chair of the British Dietetic Association, and has a background in both clinical practice as well as educating tomorrow's nutrition workforce. We're also joined today by the NNed lead medical advisor, who comes from a background in occupational medicine, been a Rajpur and has a keen interest in some of the medical challenges that are associated with implementing nutrition into practice. And we're joined by two of our team members who are nutritionists, Marietta and Laura, who will be facilitating the sessions later on today. So really, we're a very diverse group, and 5 of us are here today, but we represent a much wider cross-section of professions that all intersect in nutrition-related interests. So having said all of that, what do we actually do? So over the years, we've developed several phases of work. The heart of where we came from and what we still do is to improve nutrition in medical education and provide nutrition leadership for mental health care. We also have a remit to train nutritional professionals towards research excellence so that we can have a stronger evidence base to inform practice in the future. We also place quite a lot of emphasis on evidence-based disease prevention, both sides of the coin, so prevention of the diseases of plenty, as well as prevention of those diseases which are to do with nutritional deficiency. We derive quite a lot of value through partnerships, so our hope today is that we're not just going to have a static workshop, but that we'll share our details with all of you, create some dialogue and look towards future partnership. We support workforce capacity in the UK, and hopefully this will be the beginning of some dialogue with regard to workforce capacity here, and we also do quite a lot globally. So that's what we do. Some of the common denominators that bind all of that together is really the fact that nutrition is involved in absolutely every medical condition. Another common denominator is the need for nutrition to look horizontally rather than in silos, so different professions working together, with nutritionists determining the evidence base, doctors thinking about incorporation of nutrition into medical decisions, and dietitians as those who hold the fort with regard to nutritional diagnosis. And from there, we can actually broaden concepts much more into from medical nutrition education into wider coverage of healthcare. We've had the opportunity recently, and this is really one of the things that's catapulted us onto the global stage, to follow through the progress of the Global Nutrition Report and to feed into that. That report has just been published in December last year, and you'll find that there's quite a lot of emphasis on what the public health community in countries like India needs to do. We've been fortunate enough to follow that story through right from the inception of some of the concepts that went into the report at the UN last June, all the way through to the WHO over the launch of that report. And of course, as I've been working on that, my colleague Pauline has been making sure that we have a coherent piece within our part of the world, particularly across Europe. So having done all of that, we felt that we should turn our attention towards India as one of the important targets of some of the recommendations of the Global Nutrition Report. And we began our Indian adventure last year, and in fact, we have a paper that's just in press at the moment that looked at nutrition confidence and attitudes of doctors and dietitians in the city of Kolkata. We have a particular focus on Kolkata since there are so many institutions of national importance in public health and nutrition located here. And what we found was a very curious split between confidence and concept, and really that drew out for us some of the gaps which we hope we'll begin to fill, not just through this event today, but a series of other events that we're involved in. So I've been talking a lot. Let's just stand back for a moment and think about common terminology and language. So if I were to ask this audience that recalling definitions, so how would you define nutrition? You all come from different perspectives. Anyone want to just give us a definition for nutrition? So I'm going to just sequentially go from first row backwards. So I'm looking at smiling faces here. We've got competition, 2 hands up at the same time and a lady standing. How would you define nutrition, Mary? Do you want to repeat that for the benefit of the audience?
So nutrition, it is the science that deals with the food from its ingestion, digestion, absorption and elimination.
Okay, so that's the physiological definition of nutrition. Any other definitions that you'd like to share? Okay, so we actually take a very simple view. So this is the definition of nutrition that's coined by the UK Medical Royal Colleges, and we simply talk about nutrition being 4 pillars. So dietary intake, what you eat, which defines your nutritional status through physiology, what you are. That in turn defines your functional capacity, and then there's an overall goodness of fit of diet and nutrition and nutrients within that, to what you can actually do physiologically. Diet, on the other hand, is all about the composition of how you define nutritional exposures, and that's the simple way in which we break nutrition up, draw out the relationships with diet, and that allows us to think about malnutrition, which is actually another interesting concept, and it's a consequence really if you've got prolonged either inadequate intake or excessive intake or an imbalance of specific nutrients. But in the UK and in Europe, we have a very specific problem which we're facing. So on one hand, we have some of the highest GDPs in the world. We have some of the highest rates of overnutrition, obesity, and metabolic syndrome. But on the other hand, we have an aging population, and we have a shocking prevalence of undernutrition, particularly within our vulnerable age groups. And this really poses a big challenge for us. And I'd be curious to know through the rest of the workshop and the interactive groups that we'll be running today as to what that situation is in this country and how we might think of it from not just individual management points of view, but public health and policy. And this brings me to the well-known concept of the nutrition transition. So this was postulated by Barry Popkin at University of North Carolina, Chapel Hill. So this is an evolutionary paradigm, if you like, that describes a transition if you go from left to right, from pattern 1, so Paleolithic hunter-gatherers, all the way through to patterns 4 and 5, where we begin to see non-communicable diseases, and then there's an ideal pattern, pattern 5, which we're all trying to work towards. So in pattern 2, early on in evolution, we saw quite a lot of nutrition deficiency, i.e. undernutrition, short supply of key nutrients. And in pattern 4, we see obesity, non-communicable diseases, and the whole metabolic conundrum that we face. What is actually happening today is a merging of these patterns so that they overlap, not just in the Western world where I've described both problems, but also across the world, and it affects different populations, sometimes the same populations, the same individuals even, through the life course. And this poses a huge national policy challenge for public health in particular. And that's really something that I'd like to put to you as a challenge to think about. And really, it's all of you who can begin to solve that in future. So what can you do? Well, firstly, be aware. It's very easy in the huge noise of other bigger public health issues, so Ebola is the big one at the moment, for nutrition to get lost in ether. But remembering that nutrition and malnutrition in particular can develop quite insidiously even before you've actually detected it, and it begins to interact with other comorbidities. So that is really one of the key issues that makes nutrition so cross-cutting across different disciplines. The double burden needs particular attention. We need to think about screening methods, not just at population level, but individual clinical screening, assessment methods, who does the assessment, how do we manage that from a healthcare delivery perspective, and the Global Nutrition Report really emphasises the need for continued surveillance, and that really cannot be underemphasised. So I think what we should be doing, and our group believes, that combining specialist knowledge, if we add up all the knowledge in this room, that's quite phenomenal, but adding that to the power that comes with change management and leadership produces something quite special that allows us to navigate barriers. So at this juncture, just before we go on to the next segment, where Pauline's going to talk through a little bit of the the generic concepts. We're going to ask all of you to fill in a quick questionnaire. It shouldn't take you any more than 5 minutes. I think it's been distributed to you already. We're going to pause for just 5 minutes and continue with Pauline's segment thereafter. Just a quick announcement to say that because we started at 1:45 rather than 5:30, we will be finishing at 5:15, just for those of you who need to quickly exit for other things. So just note that timing, please. Thanks.
For us, that's what we are. That's why we're medicine, be it in dietetics, be it in nutrition, be it in public health. We're there because we care, because we want to get and optimize the nutritional well-being of our populations. Also, because our families, the patients we're dealing with, taking that right through. So again, a very important role that we have. We're a decision maker every day in everything that we do, be it in what we're looking at in our own practice, be it what we actually are doing again at a population level. We're making decisions, and we've got to keep making those decisions. We've got to look at how we can really promote nutrition. To me, communication is the real body that pulls that all together. Nutrition communication is the cement of everything that we actually do. But again, I suppose I'm going to say I'm a dietitian. When I speak to a medic and another doctor, another healthcare professional, I speak almost in one type of language. When I speak to my patient, I speak in a different language. And again, it's how we actually bring that together and give ourselves the confidence that we actually are properly understood, no matter what we're doing. I suppose when I look at some of the work that's happening around the world in looking at that standardised language, as it were, if I pick something like nutrition support in America means enteral nutrition, parental nutrition, so something where you're actually physically doing something to the patient. If I come back to the UK, it also means food fortification, so being able to actually give the patient, you put more butter, put more sugar, actually get the nutrition into the patient that we need. It also means oral nutritional supplementation if we actually need that step forward. And I think if we want to get the best care for our patients, we've got to start with food first, with food fortification, and build that up. But again, if I'm talking to colleagues from the States and I'm going nutrition support, they don't necessarily understand what I'm talking about. So that's something that we've got to be very aware of, and I think we've got to look at the leads that are happening across the world in that international standardised language. Like a dietitian, we have got our language. The medics, you're either working in the International Classification of Disease or the International Classification of Function. And while that is the disease and the disease function and is right and proper for actually giving someone the medical diagnosis, when it comes to nutritional diagnosis, how relevant is that going to be? So what I'm talking about really on the back of that is if I say diabetes, if someone has been diagnosed with diabetes, what does that mean in nutritional work? What are we trying to do? We're trying to optimise the glycemic control. We're trying to ensure that that patient has the best glycemic control, because then they're going to have fewer complications of the diabetes. So again, it's all of us working together, and we can only do that if, as individual healthcare professionals, we come together for the betterment of our patient, for the betterment of population health. So that's very much where I see that communication. Taking it on to be a community leader. What again am I talking about? Some people think leaders are leaders. They're the people that are standing up in front. And yes, they are. But every one of you in this room is a leader as well, and must be a leader. And that goes from a junior medic, and a junior dietitian, and someone who's just stepping out into the public health arena. You've got to believe, well, I know you've had the qualifications, you've had the training in your specific discipline. You are able to lead. You know more about that than other people. Okay? So again, I'm expecting, and that's what I would be expecting my students. I'm telling them, when they go out there, they've got to stand up, they've got to say what a dietitian does. They've also got to understand what the speech and language therapist does, or the physiotherapist does, and how they bring that together. Community, that whole leadership, it's leading, as I said, at bottom, sort of ground level, taking those steps. How you might again sort of communicate and manage that time, manage your efforts. That's where the management comes in, and being an actual manager. You manage time, you manage efforts, you manage your knowledge base. For all of us, no matter when we graduate, that's not the end of our learning. We have got to continue to learn, optimise the health of those that we care for. So really, what is making that the good healthcare leaders of the future? And I think it's that ability to know your environment, to know where you work, to understand where you are working. It's there where you're going to assess accurately the needs of those you lead or those that you report to. Because again, if I was a dietitian working in a clinical ward, working in an intensive care unit, I sit there, I have my consultant intensivist who actually, we're working with him to help our patients. But if I'm sitting in the catering department, I'm leading a team of people to actually help them to improve the catering services. So I play very different roles as I go through that, and that's the bit that's important. I think again, it's about understanding your own management style. Some people are almost born leaders. People want to follow them. Other people they do it in a very, I don't mean a backward way, but they promote other people, they empower other people to actually get on and do that work. And that again is vitally important. And I think it's about adjusting the style of your leadership, your management, as you go through and understanding how that actually works. And that's one of the key things that we want to challenge you a little bit, to really begin to understand you. I mean, again, I will say to my students, to my practice educators, if I don't understand me, don't understand how I work, how can you empower, how can you get other people to understand what is needed of them? So that flexibility is vitally important. But again, it's communication and it's caring. That's what we're here to do, and that's what is so important about everything we're going through. I said leadership and management are not one and the same thing. We know that a manager is an individual who holds that office and who manages specific tasks. The leader, as I said, is someone who leads people. That can be because they're powerful, because they're empathetic, all of those areas. And as I said, I can't stress enough that from being the most junior member of staff, you are a leader and must be for nutrition and for the sake of nutrition. Just getting you to think very quickly. Who influences nutrition in your healthcare setting? Do you influence it? Do your patients influence it? Do your managers influence it? Do other members of the healthcare team influence it? These are the questions we want to delve in a little bit more when we go through the workshop. So really starting to think, what makes you, what influences, what are the factors that you've got to recognise if you want to change those? And again, it's understanding the various professional groups that are there. This is an example from the National Health Service, but I think it's something where you begin to think about who you're dealing with. Now for us, we say a range of diversity of stakeholders. Are you familiar with the name stakeholder? Some people not. A stakeholder is someone who has an interest in what you're doing, in the work that you're doing. So you can look at, take an example we've all been through. At college, you have got yourself as a student. You want a qualification, so you are a key stakeholder in what goes on. The college itself, because they need students to come through so that they can grow. You have got the lecturers. If they didn't have you and didn't have the college, they would have a job. So it's those people that actually have something to say. And obviously for us, our patients, our population, are one of the key things that we need to do and think about. The NHS is complex. Thank you. Is complex, and there's a lot of resourcing that goes through. Thank you. The NHS is a complex organisation, but any healthcare unit you work in, I think when you're dealing with people, it really is challenging. We've also got professional autonomy, and again that works at different levels across the world and the international platforms. But if we think about, I know in the UK, a professional dietitian, an autonomous dietitian, that's what's expected when the dietitian graduates and starts work. At that point, they have got to be able to think for themselves, they've got to be able to do evidence-based is practice, they've got to be able to take the fitness to practice, they've got to be the leaders and the managers as far as education and nutrition goes. So again, it's how that all links together, because if I say, well actually, I'm an autonomous practitioner, my physiotherapist says the same, my medic says the same, you can end up with 3 or 4 or 5 or 20 very dominant people. You've got to work together, and it's that understanding and flexibility that comes with leadership and management and change that is so vitally important. I think this slide is just very much showing us that I suppose there's that bit of peak performance right at the top where you're being challenged, you actually are performing well. People, if they're not challenged, they end up actually just being bored in their job. They want to be challenged, they want to actually get the best out of that. Mind you, if you're challenged too much and you perform too high, you're going to burn out at the other end. So again, we just need to be mindful of where you're looking at getting that balance. As I said, we've talked about the attributes that are needed, the communication skills, vital. Being assertive, again, you be assertive because you know the facts. You know your evidence, you know your knowledge. You can stand up and say the evidence says, the research says, and that's the ground that you work on, and that's how you deal with conflict as well. You deal with it by understanding what actually is happening. With numeracy and data handling, again, we all know how we look after the pennies in our purse, okay? You do a lot of that, either calculating requirements or looking at the energy intake, the energy output. We've all been given those skills or taught those skills. If, as we go through and you find that they get more complex as you're looking at service evaluations and audits, well then you look at getting extra training or actually working with the expert to help that happen. I think as I talk about service evaluation and audit, we need to know we can't do things and just say, I'm going to do this, and that's it. You've got to measure yourself to see if that worked. And that's what's really important, that you have the best outcomes for your patient. So you set something up, you do it, and then you check against that to see what's happening. And again, it's the time for the strategic thinking, where you come together as dietitians, nutritionists, public health, medics, to actually say, this is where we want nutrition to go in our organisation, and how we can actually make that happen. I suppose for me, a diagram like this is the building steps as to how you get from one point to the other. Sometimes it's not quite as easy as just going up those steps. You might go up 2 steps and back down 1, and up another 1. But again, it's not about giving up. It's about understanding if you want to change something, why it's got to be changed and how that's got to be changed. I suppose if I look at it, to me, okay, I'm going to football. Yeah. Can you hear me at the back? If I stand over here just for a minute? A football here, okay? I probably should say it's an orange, but I'm going to say it's a football just for now. It's sitting at my foot. To get that to the person right at the back, what am I going to have to do? I'm either going to have to kick it or throw it, alright? To make that happen, I'm putting energy in. I'm putting momentum in to get that to happen. Person at the back though, I need you to catch it, okay? I need you to stop that, and that's what happens to change. Change, you build up, you actually see what needs to happen, you then try and do something about it. Energy goes in, you manage that momentum. Obviously if I try to kick and I kick out this way and it goes there when I want it to go there, I'm going to have to get John over here then to kick it down. So you're going to have to think how you work with people to get that, to get the change there. But when it happens, you've got to stop it. You've got to say, okay, I want to do this, I've achieved it. Stop it, embed it, and then work it again. Okay? So that's very much how we work through things to sustain the efforts and the benefits that we have. Well, I think that's me at the end of all of that. Thank you very, very much indeed.
Thanks, Pauline, for taking us through the bare bones of what constitutes change management and leadership. How if you can identify with a situation where you have actually made a sustainable change? Hands up. Either in your education system or in the healthcare system that you work in. Okay. Anyone who feels that they have made a sustainable change? Nobody? Okay, we're going to fix that this afternoon. Anyone feels that they have untapped leadership potential? You're the one who can lead, but you're not heard. Anyone feel that way? We're going to fix that one too this afternoon. Okay, right. So I'll tell you a little bit about what we did in the NHS, which you might know a bit about, and Pauline's described some of the complexity of the NHS as well as some of the challenges. So you can find this paper on PubMed. It's called Nutrition Education Leadership for Improved Clinical Outcomes. What we did was we decided to run an experiment. We got together 3 teams of very junior doctors, so doctors who had just graduated. We gave them some nutrition training. All of these teams comprised doctors who had had some nutrition training as undergraduates. We gave them some more intensive nutrition training around some key challenges that the NHS faces. We then teamed up with the Judge Business School in Cambridge to give them some change management and leadership training. And what we did was we created 3 teams in very different parts of the National Health Service. One which had a large ethnic minority population. So for those who know, the Midlands in the UK has quite a large South Asian ethnic minority population. One which is in the home counties of the south of England, which I think the cricket enthusiasts will know a bit about. And another one which is out in the Fens. So really that's the extreme east of England, and that's where we have quite a stable ageing population. So 3 very different demographics. What we asked these teams to do is to use the training that we had given them to go away and run effective nutrition awareness weeks. In these weeks they did audits using what we call the Malnutrition Universal Screening Tool. We encouraged them to run train-the-trainer sessions. So junior doctors themselves acted as levers for other junior doctors to gain further insight into nutrition. And they did a number of other things. They ran nutrition awareness stalls, ran doctor surveys, staff surveys, did a fair bit of advertising on what nutrition can do for patients and hospital teams. And we ran interviews to gain in-depth qualitative insight into what was happening in these 3 regions. And these awareness weeks had quite a lot of impact. And although they were done in very different ways, they all led to improvement that we could quantify in terms of knowledge, attitudes and practices. And they led to a number of other shifts where we could see that simply one episode of education intervention given to 3 teams then had a snowball effect across 3 extremely different regions of the NHS. So this is just an example of junior doctor-led teaching where we had a bottom-up approach. So in Britain, in the NHS, we have quite a hierarchical system. So junior doctors are the ones who do back-breaking work but are often seen, not heard. And I think there must be parallels in this country and in various other parts of the world. What we did was empower these individuals with a bottom-up approach, utilise their freshness and also their enthusiasm, and we got top-down buy-in from management teams. And the combination of those 2 things met beautifully in the middle. So what we really have been trying to do through that is, in the complex system that we have for healthcare, and I must say for a country that's geographically quite small, the UK has an incredibly complex system. We have, I think, at least 5 committees to take any one decision for any small region. I think one of the effects of possibly a bit too much democracy in the way we run things. So nutrition appears nowhere, and through simply 3 awareness weeks, we've changed the nowhere to now here. And that's the sort of linchpin that we'd like to anchor our future efforts on. And in fact, the lessons learned were, very importantly, that even if you're junior, even if you're very junior and in a very hierarchical system, you do have the potential to make a difference. So, going over to you, what we're going to do now, perhaps it's not going to be exactly this time frame, but we're going to break out into, change the yardstick slightly, 4 facilitated groups. So what I'd like to do is break the audience up into exactly 4 quarters. You'll see some flip chart paper stuck to the walls. So what I'm going to ask you to do is bring your chairs as close as possible. We've got one here, another one along that side, and 2 on that side if you look carefully. So if you could split yourselves up into 4 roughly equal groups. For each group I'd like to identify a group leader. So one of you who's prepared to stand up here and say some things afterwards. And also for each group we need a scribe to help us capture some of the thoughts from discussions. What you're going to do is identify some of the, well firstly identify your interface with nutrition, and then identify some of the barriers that you've actually felt or you perceive or know about implementing or prioritizing nutrition in your own healthcare practice setting. And then what we're going to do is use some of the inspiration, hopefully, from what we've talked about, but a lot more inspiration from what you possibly know already, but don't know that you know it yet. And we're going to come up with some strategies on how you can raise the profile of nutrition in your healthcare settings. And then we'll get 4 group leaders from amongst you to each feedback for about, let's say, 3 minutes or so. Stand up here and share some thoughts, and then we're going to do a quick summing up of the day. Okay, so with that, it's over to you.
We'll be in the groups as well to help, alright? Okay. Yes.
Right, so if I could have this quarter, so 1, 2, 3, 4 rows. So from the lady in, yes, just from you, all the way in a straight line up to here. So if you can all bring your chairs around so that we can congregate around that flip chart. I mean, we're going to have to be slightly creative about how we do this. I'm not sure how much we move things around. And then from this line onwards up to that end, you could use this station and then 2 at the back. theoretical, practical, or is that community or based both? So you're actually studying, and then this group can have a discussion. So start discussing how to study. Okay, Marietta and Laura, can you get your group to use the roving mic to feedback, please? Can I have one of the roving mics at the back, please? Okay, turn your attention that way, please.
Hello.
Yep.
Hi, I'm Mahashweta. I'm from VIT University. I'm a biotechnologist. So what we discussed here is who influences nutrition in our healthcare setting. So is it just the doctors or the nutritionists or the dietitians or other healthcare professionals such as nurses? Sometimes the doctors can refer the patients to the nutritionists. It is also the patient's choice because they can choose to be having a better healthcare for themselves. So even they can go to these dietitians and because they are really concerned about their health. And we discussed the barriers in nutrition. Sometimes we see that nutritionists refer patients to doctors more often than the doctors refer the patients to the
Excellent
nutritionist.
point.
So that's one of the barriers. And the second barrier was that sometimes like the nutritionists cannot prescribe some of the drugs such as the iron supplements. So for that the patients have to go back to the doctors and have them prescribe the drugs. So if we could have a unified system, it would be much better. So these are the two solutions that we came up with.
Okay, anyone want to add any comments to that from the Fitzpatrick?
Which is affordable, and then which has no cultural or any other economical barriers. And then and about the food equity, so that everybody gets enough food. And then one more concept was to reduce the wastage of food that happens a lot in the country, in restaurants or at homes, and to maybe recycle it or redirect it to people in need. And then nutrition education to everybody and target the children, pediatric age group people, and the mothers, and even in schools. And also to portray it in a cultural point of view, because people will understand it better in this country. And then to change the dietary beliefs by constant awareness programs, and also to address the storage problems and the production problems. Okay, and the analysis we did was to do networking and to talk about evidence-based nutrition-related issues to people, and to pull up the like-minded people so that we can work together and make a difference. And to prioritize the list of things that we need to do, because if you keep piling up everything on a common person, then he might not understand or get the actual point of it. And then to change, this change has to come from self-level, and then we can attach it to the emotional point of the person, because you can ask to create awareness in his own family and then in the whole community. And then to introduce nutrition in the curriculum for schools in every level of education, and even in the professional levels, because once people grow and go to the medical schools or other schools, engineering courses and all, they do not know much about the actual facts of nutrition. So you can introduce it in all curriculum, and to give an integrated way of clinical practice by doctors, by adding nutrition in every aspect of their clinical career.
Thank you, and I think that's a really nice complementary approach to the previous group, perhaps achievable in only one lifetime. So thank you very much. A round of applause for that group. Now the penultimate one, so this is the Rajput Ray group. Over to yourselves.
Thank you very much. We've had such an amazing interactive session here. Can you hear me? Yes. Great. So we actually have 3 spokespeople, but they're going to be very, very brief. And I'll start off with Anand.
Hello everyone. I'm audible. Let's show this. Yeah. Sorry. Am I audible now? Yeah. Okay. Great. Initially, Dr. Meena should discuss about the refilling syndrome case, which she observed in Scotland, and then we started talking about nutrition issue, and we took it at a global level, considering that nutrition is not the problem in only developing countries, it's also evident in developed countries. Then we started thinking about what are the possible areas where we could work further. And the first important thing what we found was evidence-based recommendation. There is always need of concrete evidences to work in the area of nutrition to improve the health of all. Secondly, the belief and perception, considering India, a diverse country, that we have a large number of people, large number of groups, different types of diet. We could probably look into the beliefs or the myths involved in their, the different types of food preparation, food types, and then that's how we got into the government food distribution system. So if you think about the ICDS, Integrated Child Development Scheme, then we thought about having something like an audit which could ensure that each and every child in the country will have a safer and better food every day, which could improve their nutrition. And the last important thing we thought about that the awareness of gaps. There is definitely a significant difference between urban and rural areas. And then we thought about the affordability, the difference in availability, accessibility of food resources, and at the end of the discussion, we also thought about difference between dietetics and nutrition. So we thought that the diet is basically what you see in the plate, and nutrition is something what happens within your body. So after this, to discuss further about doctor's role, I'll hand over to Nishta and she will take further.
Hi, I would like to mention, as a doctor, if we get a patient with stroke, how do we go about it? Like, it's not the doctor's sole responsibility. A collaborative and a comprehensive approach is required. Now, a patient with stroke comes, so we require a speech therapist, we require a dietitian, we require a nutritionist, and also we might require a physiotherapist because the patient might be paralyzed. So we need to make sure that there's a collaborative approach. It's not the doctor's sole responsibility, and also it's important for the doctor to get feedback from all the arenas, from the dietitian, from the physiotherapist, in order to ensure better patient and healthcare.
And now we have from the nutritionist and dietitian's approach.
Good afternoon, everybody. I'm Subrata Karmakar, Deep Diet from doctor. Not only doctor have a major role to fulfill all types of criteria. Dietitians and nutritionists, they completely plays a major role to recover patients from various types of disease or various different deficiencies. Dietitians is a combination of arts of science. That's type of technique dietitian use to feed how to feed all types of patients or general public or communities. And nutritionist plays a role to different types of support. We are all needed for doctors, dietitians and nutritionists. We are all need to fulfill this criteria.
Okay.
Thank you very much.
Okay, well, a round of applause for that group. I think what they've effectively done, so you can see that we all had a common stem to start off with, but each group has been taking a different approach, and this group's approach has been really multidisciplinary. I think that's the common denominator there that they've teased out between things to do with primary prevention, secondary and tertiary treatment, but also different professional groups, so well done for that. Last but not least, so the RAID group, the largest group by number, over to yourselves for some independent thoughts which I did not facilitate.
Started our conversation with the main theme for the barriers for implementing or for prioritizing nutrition in the healthcare and public healthcare processes. So we came up with three distinctive phases, like the barriers can be primary, secondary and tertiary. Among the primary barriers, there can be lack of awareness, illiteracy, poverty, lack of proper source of knowledge, and family size becoming smaller. So let me first start with the lack of awareness. Lack of awareness, like there are a lot of knowledge around us. Like we can just Google something and we can find a lot of information. But to choose from among what is right and what is wrong depends from people to person. And a trained person can only see through it that what's correct and what's not. Moving on to illiteracy, as we know that not everybody is literate in terms of nutritional knowledge. So we can focus on nutritional knowledge being implemented at all the stages, right from the school, colleges and all the other professional courses. Moving on to lack of, like family size is becoming smaller. The family sizes were initially bigger. We had joint families, so we could have the advice of the elderly people. But now the family size are becoming smaller and the parents are working parents. So a child is deprived of the nutritional knowledge and proper nutrition, and the child is often seeking to easy to make foods and food made out and processed food. So this is another barrier to nutrition. The secondary barrier being the doctors taking the place of nutritionists. negligence by patient as well as their caregivers. Like most of the patients are not well aware of the nutritional status. We are just aware that we are having fever or we are having diabetes, so we rush to the doctors, the specialists to have some medicines. But we never think that we should go to a dietitian first and take some advice on our nutrition and diet related things so that we can improve and we can have a better nutritional status as well as better health. And most of us often seek advice on diet and nutrition from the doctors and not or rarely visit the dietitian to seek nutritional knowledge. So that's again becoming a barrier. And then moving on to tertiary is the poor health and immunity, which is again a result of poor nutrition, and this again contributing to a poor nutritional awareness and knowledge. The other things can be like medical intervention is often at the stage when the problem has already occurred, and not on the subclinical stage. Like we rarely identify that we are having malnutrition or any nutritional problem before it is being manifested. So once it is manifested, then we rush. But before that, we do nothing. But if we try and focus on the nutrition, a proper balanced diet, having a proper lifestyle from the very beginning, so we can avoid all those circumstances. Then some people have preconceived notions about some diet or dietary facts, like any kind of food fad or food taboos, which can be a barrier of nutrition. Then there is another thing that people generally have hesitations to clear their nutritional doubts or ideas. There is a lack of proper knowledge source, as I said. Then there are different types of processed food, easy to cook foods, focused on TVs, newspapers as being healthy, claiming to be healthy. These claims often mislead people and they consume processed foods. Then again, we are having like some of the edible oils are marketed as saying that they are cholesterol free, but actually plant sources do not have cholesterol. So these false claims are often misleading to people. Finally, we have false data from the people, like the patient visiting the doctor or the dietitian sometimes tend to do not provide proper knowledge, and there's no uniform system as required. A person with a proper nutritional knowledge should lead the nutrition team. And finally, that education of nutrition has to reach and cross all these barriers at school, colleges, and institutional levels as well.
Thank you very much. Are there any other further comments from that group? Those are behaviours both in the healthcare community and for patients. It's not really going to result in change. So I'd like everyone to give this group as well a round of applause. And now, if you could just be seated for the final 10 minutes, we will close this afternoon. So my colleagues are going to circulate another brief questionnaire. So as soon as you're seated, if you could start completing the questionnaire, and then we're going to get Dr. Minaraj Purre to sum up the day, and then I will add a few closing remarks.
I'm one of the lead medical advisors. Following the group session, this is going to be the summary. I just need to have your attention for a few minutes. I want to ask you all one question. How many of you here have had toothache? Raise your hand. How many of you have had toothache? And you wonder, why is this doctor asking me this question? Can you eat when you have toothache? You know how terrible it is? Okay. I'm going to ask you another question. It's a bit of a sensitive question, but I do not need any show of hands. How many of you here have had indigestion? You've all had. And you don't eat well. How many of you have had family members or friends who have had a heart attack? Okay. How many of you have maybe unfortunately know somebody who's had a stroke? Now, there you go. How many of you have known a patient who's had cancer? this is where we are. If you look at the common thread through all these areas, you can see nutrition. Nutrition is one specialty area, and by nutrition I mean nutrition and dietetics, is one area that will touch every aspect of not only medicine, it will touch every aspect of your lives. Whether it's from when the lady is pregnant, to what she eats, to what the child eats as the child is growing up, to what the teenager will eat, to what the person will eat in their 20s, 30s, 40s, and when they are elderly. So I hope this session has given us an opportunity to be able to look at all the common threads through how, not only how important nutrition is, but also how we can make a change. Each and every one of our groups, again, had a common theme. And the theme was that whether we are students or professionals of nutrition or dietetics or medicine or speech or language therapy or pharmacy or physiotherapy, or if we are a researcher, my group has a researcher as well from the University of Nottingham, we all want to say that we can all make a difference. Why? Because the patient is at the center of this equation. And I will share with you a very simple tool that I learned when I did my training in London and in Scotland. And this simple tool I have utilized at many, many junctures in my professional career so far. How many of us have come across the Vitari box? Hands up. Has anybody come across the Vitari box? Not a problem. You have come across it now. We'll go through it very, very briefly. So, my attitude, which means my confidence, my level of knowledge, my level of awareness, my want and desire to help my patient, my want and desire to educate myself and my family, my friends and my colleagues will basically affect my behavior. In my group, we had some people who have spoken, in public for a number of times. We had one particular person who is not spoken very much in public. And why is it that, we should not give other people who have not had a chance to speak in public that opportunity? Well, not the case. Confidence is very important. So, my attitude, are you all with me? Yeah. Will affect my behavior with myself and my colleagues. And by this I mean the multidisciplinary team. How the doctor interacts with all members of the team and how those members of the team give feedback to all the doctors. And there's a saying in Hindi that, your 5 fingers have to work together to make your hand a functional hand. So in the same way, my behavior then will affect your attitude. If you have a doctor, who says, oh no, I don't care about the dietitian, I don't care about the nutritionist, what will happen? Then the nutritionist and dietitian will not feel empowered, yeah? So as a doctor, I have to make sure that I can be able to very much keep in line with what Pauline said, with what Shamantra said about I have to make sure that I am open and accessible to listen and implement what my colleagues are telling me. And likewise, basically, therefore your attitude will then affect your behavior. Because if I'm open to you, if I say, okay, Ankita, come here, listen to me. We had in my group, or we say, Anand, this is what we can do for research, then you will come back, So your behavior, you say, okay, Dr. Minha, I think we can do this. And then your behavior will further make me feel more empowered and make me feel more confident to be able to say, okay, stage 1 we have completed, now let's do stage 2. So I sincerely hope that this will affect us not only as colleagues, but also from a junior to senior level. Just for the ladies who are leaving, just to say briefly, never feel that you can't challenge your seniors. It's how you challenge your seniors that's so important. But being able to have this little bit of a little gem within yourselves, that's why it's really important. And I pray and hope and I request that this workshop has given you those few skills out there in your board rounds, in your interactions, and finally be able to make a difference for the sake of your patients. Thank you very much.
Thank you, Minna, for that really very thought-provoking and passionate sum-up of the day. And I hope that all of us can take away the Batari box to place our knowledge in, and from there, hopefully we will see things through to implementation. So just to sum up with a few concluding remarks, I think it's fair to say that after this afternoon, I'm convinced that the enthusiasm which all of you have shown speaks for itself. The fact that we said that we would spend 3 minutes, but actually spent a lot more, a very involved time, I think says a lot about what all of you can actually do. And really, together and across borders, what we need to do is work together to make nutrition a priority. So I've put a number of bullet points up there, but one of the things that we don't often talk about is what has gone right. So we've spent a lot of this afternoon talking about some of the barriers, some of the problems, and in fact sometimes that leads us into problem solving, which is what we've actively done today. But the passive processes, it leads us into a cycle of complaining and looking slightly negatively at the glass half full. What I'd like all of you to go away and do after today is also to think about the very many examples, which you may not know of until you actually think of them, of where things have gone right, of where you are doing the right thing, of where actually, in many ways, this country leads the peace compared to some other countries, where there's provision within health services or within instruction within this country or this region of the world, where nutrition actually is doing things right, is getting things right. Why do we not talk about those positive models? Part of it is because we don't always add legacy to what we do. So I'd like to appeal to all of you there, as a researcher myself, to please document what works, and more importantly, document what doesn't work, so that we're not reinventing the wheel, and so that we can have a trail of peer-reviewed, published material behind us to help us guide ourselves into the future. And that way, nutrition, which we all know is common sense, can hopefully become commonplace. So I'd like to thank you all very much for your attention this afternoon, and we'll hand over to the organizer to say a few final words. Thank you very much.
Thank you, Department of Biochemistry and Nutrition of All India Institute of Hygiene and Public Health to now facilitate each one of the dignitaries with a certificate for being a significant part of ISMOPH. The first one being Dr. Shuman Chore, who is the lead facilitator, and Riyadi will be assisting him. Thank you. Round of applause for him. Next we have Dr. Pauline Douglas. Dr. Laura Fitzpatrick. Dr. Marietta Sae. And finally, Dr. Minha Rajputre. Thank you, and we conclude the workshop. Thank you.
Okay, so for this one, I'm just going to say 3 cheers for the World Congress and the ISMOPH. So hip hip. Hooray! Hip hip. Hooray! Last one, hip hip. Hooray!
Where's the iPad photo? you very much. You're all leaders.
তোমার তো হয়ে